Okay. Hi, everybody. This is Rajam Roos. I'm the CEO and founder of the San Diego Pain Summit, and I'm being joined by Karen Litzy today. And Karen Litzy is a doctor of physical therapy therapist, and she's an international speaker and also host and creator of the Women in Physical Therapy Summit that she has I believe it's in October in New York City. And through her work as a physical therapist, she has helped thousands of people overcome painful conditions, recover from surgery, and return to their lives with family and friends. And as a podcast host, she's interviewed influencers in the worlds of health medicine and entrepreneurship, including Gloria Steinem, Dr. Karim Khan, J.J. Virgin, and Professor Lorimer Moseley, just to name a few. I kind of slurred through his name right there. Lorimer Moseley. And she's also presented on a variety of topics, including her personal journey with chronic pain, the neuroscience of pain, and utilizing social media as a medical profession and technology and informatics in healthcare. And she's been featured in a lot of magazines. You'll see all the rest of her bio on her page. She's done a lot in her young life, and she's now based in New York City. So she's taking some time out to have this discussion. And Karen, you were talking to me about, you've been dealing with persistent neck pain for a long time, and then it got better. And now you're saying you woke up with it this morning, and you were thinking about how it is from the patient's perspective if they have a flare up and then they're freaking out because they think they're right back to square one. And so as often what clinicians do is just maybe shut them down, or, don't listen to them, or just say, who knows what they say. But what would be an appropriate way to have that discussion with your patient in that case?
Yeah, I think, like you said, I woke up this morning and had a lot of pain. So you'll see I probably won't be turning my head very much during this interview. But what happens from the patient standpoint is you wake up, and I know a flare-up doesn't mean freak out. But the first thing I did when I woke up this morning was I freaked out. And I thought, oh my gosh, I can't move. I don't want to move. I have to move so gingerly. Maybe I shouldn't walk so much. Maybe I shouldn't do this today. Maybe I should just lay in bed. Should I take medication? Should I not take medication? All of these things are running through your head really, really quickly while I'm laying in bed trying to figure out which way to roll. Should I roll to my right? Should I roll to my left? In order just to get out of bed. So they're the first things that are going through my mind the moment I felt pain and my eyes opened. And so as the clinician, think about what I just said when you're speaking to your patients when they've had, let's say, a flare-up. And yes, flare-ups don't mean you need to freak out. And that is very, very true. Normally a flare-up is just that. It's the nervous system might be sensing a threat from somewhere, whether it be internally, externally, a threat to the system, and you're having some pain, you're having some physical symptoms. It could be pain, it could be tingling, it could be a feeling of tightness in through the limbs. Does it mean that you've damaged yourself again? And the answer is most likely no. And I think that's the big message that you want to get across as the clinician to your patient, that flare-ups are going to happen, even if you've been pain-free for a couple of years or relatively pain-free for a couple of years. But flare-ups can happen. They most likely will happen. And you don't want to freak out about them. You want to try and get up, try and move and go throughout your day as best you can, because we know that the nervous system and the body loves movement. And so the more that you move, the better you're most likely going to feel. And I think the other thing that therapists need to take into consideration when you're talking with that patient is, number one, don't just dismiss it. So yes, we want to say it's just a flare-up, don't freak out. And I just said it. Don't use the J word. That is like the worst 4-letter word, right? Just. Because it's not just a flare-up. It is a flare-up. And for the person experiencing it, it's pretty scary, especially if it's their first flare-up after they've been relatively pain-free after bouts of persistent pain.
And even for you, I mean, you know, you're educated in current pain research, and you've been working
Yeah.
from this perspective, but listening to you describe all that was going through your head when you woke up before you even figured out which side to roll over.
Yeah.
So, you know, do you
Yeah,
think
I
it's a good
think,
idea? Oh, I'm sorry.
no, I was going to say, as the clinician or as a therapist, have a little empathy. You know, if someone's coming in and they're saying, I'm having a flare up and they look like this and they can't move, don't be dismissive. The first thing you could ask them is, okay, you're having a flare up. Tell me a little bit more about that. That's it. Not what does it feel like on a scale of 0 to 10, or can you do this? Can you do that? Tell me a little bit more about it. What's happening? And just let them speak. And then when they're done, show a little empathy. You know, say to them, okay, I hear you. I understand your fears. I understand your frustration. But please know that flare-ups are common. You may have them. It doesn't mean you're damaging yourself more. And now let's look at the physical symptoms coinciding with this pain, which it might very well be tightness of the nervous system. It might be balance issues. It might be muscular tightness. So let's now give you some options of how you can treat this on your own the next time this happens, to number one, give you some confidence to know, like, hey, look at, I actually had a flare up, I did this, and now I feel a little bit better. And number two, it gives you a sense of control. And number three, it gets you moving.
And is that a discussion that you would recommend that clinicians have early on in the treatment plan, as opposed to waiting for that flare up to happen? Or what is your perspective on that?
I mean, I would say don't have it on day one. So if someone's coming in and they've had a couple of months or years of persistent pain, don't say, hey, we're going to work with this and your pain's going to go down to levels you can live with, but watch out, you're going to have a flare up. No.
Just a flare up.
Yeah, I would say, let's have this conversation. Let's kind of weave this in as treatment goes on. So as they're saying, you know, I'm starting to feel better, or I was able to do X, Y, and Z, and I wasn't able to do this before. That's the time of saying, you know, this is amazing, and you're really progressing quite well. I do want to let you know that oftentimes with people with persistent pain, sometimes they'll have flare-ups, so that pain will spike a little bit, but it'll go back down again. And it won't be this spike for months and months at a time, and then it comes back down. But maybe it's a couple days, maybe it's a couple weeks, but know that you haven't done more damage to yourself. I mean, like this morning I woke up, all I did was sleep. I'm pretty sure I'm not like, you know, swinging off the bed, you know, and flailing myself onto the ground, or in a way that I'm doing something that's physically going to injure me while I sleep. And so I think the important thing here is remembering that, yes, it's a conversation you have to have. As a therapist, yes, maybe it's not the most pleasant conversation to have, because we always want, if people are on the road to recovery, we want to keep them there. We don't want to scare them, but it's not scaring them, it's preparing them. So there's difference between being a scare and being prepared. So had I not had the knowledge in me to know that flare-ups can happen, and I woke up one morning and felt like this, I would be like, oh my God, it's back, it's back, it's back. And you know what happens, you know, your nervous system gets dialed up even more. Your stress levels go up, release of cortisol comes out. I mean, all of these chemical reactions that happen in the body, and then you say to yourself, well, I better not do anything. I better stay still, let's see if it passes. Or you reach for medication immediately. Instead of saying, okay, the therapist said a flare-up might happen, so this is not unusual. I'm not damaging myself further. And these are some of the techniques or the exercises, the movements that my practitioner told me to do. So I'm going to try those first. And then after a couple days, if they don't work, then you can go back to your therapist. You can say, hey, listen, I'm in the middle of a flare-up. Can I come in? Can you take a look? But I'd much rather have a well-informed patient than someone who doesn't know because I, as the clinician, was too scared to tell them.
Yeah,
Just
and
feel free
I'm
and all
curious.
the time.
Mm-hmm. And I'm curious, like, what does that look like to talk about, just kind of segueing into if you're dealing with a patient who is recovering from surgery or an injury or anything like that. And you mentioned earlier, before we turned on the camera, we were talking about how clinicians have a hard time being honest and upfront in their discussion with their patients. And so what does that look like to be able to do it with compassion, to talk to them about the reality of their situation and explain that there may not be a magic pill that's going to, help them get exactly back to where they were?
Yeah, and these are hard conversations to have. I'll take the example. So what I'll do is I'll take the example of, let's say, someone who had an orthopedic injury, let's say an ACL injury. So before that patient even has surgery, or if they decide to have surgery, it's important for the therapist or the physician or any healthcare practitioner working with that patient to give them the facts of, this is what surgery looks like. This is a realistic recovery timeline from surgery. This is what surgery may not look like. This meaning maybe you don't need surgery. What do you plan to do? So I think how you do that with compassion is, number one, you get to know the patient. You understand, well, what do they really need to do in their life? What can they live with? What are they okay living without? What can they move on with their life without doing? So let's say, again, we take this person recovering from an ACL tear. They have not had surgery yet. They're in their mid-50s. Maybe they're not doing court sports. They don't need to do things that require them a lot of stops and pivots and things like that. And they're strong and they feel good. We need to tell them, like, listen, this is what happens when you have surgery. Maybe you can try some rehabilitation for 6 months, see how you feel. If it feels like, okay, I'm still feeling unstable and I'm still feeling weird and I want the surgery, then you can always have the surgery. But I think the best way to do that is to do it with facts, to show them, hey, listen, here are some studies. This is what these studies show. And then you have to give them all of the facts and all of the available information we have at our disposal, and then they make the decision. And you need to give them the facts and stay out of it. You're not there to manipulate them into doing one thing or another. It's the same with someone, let's take someone with persistent low back pain. And they went to a surgeon and the doctor says, well, we can do surgery on that. Well, we know that 49 or 50% of people who have low back pain or have back surgery for low back pain still have back pain. So these are things, this isn't being manipulative, it's not being the bad guy, it's just showing them facts. And then they make that decision. And we have to, as a therapist, take our egos out of it and allow them to make whatever decision they feel is best for them at that moment, given the information that they have. But it means giving them all the pros and all the cons.
And leaving our bias out of it, because that's...
And leaving your bias out of it. And oftentimes patients will ask, well, what would you do if you were me? And I'll say, well, if I were you, I don't know. My lifestyle is different. I have different considerations to take into account. You can't, and I never really give an answer to that because I don't want to sway someone one way or another. But I'll say maybe which way I would lean toward, but you don't know what that looks like until you're the patient making that decision. But you can certainly give as much evidence and facts and information as you can, but you have to have those conversations. You can't shy away from them. Even if the patient has their mind made up and they're going to do this surgery or they're not going to do this surgery, I still like to give all the facts because someone has to. Mm-hmm. And what I kind of found out the hard way was not only giving the facts of this is your physical recovery, but also looking at it from that psychological standpoint as well. So, something after you have the surgery, maybe you're not going to be moving as much. You're not going to be able to do the things that you want to do for 6 to 8 months. So you may have some symptoms of depression. You may have some symptoms of anxiety. And so maybe before we do this, let's have someone in your corner Do you have someone that you can work with, that you can refer to, that we can refer to? Do I have someone that says, this is maybe a psychologist or a psychiatrist or a life coach or a health coach that I like to work with? Let's keep them in our back pocket now. Because I had a patient who had surgery, and he said, I wasn't prepared that I would feel this kind of anxiety or depression because I can't do the things I want to do. And that was locked on to a lot of other things through work and family and things like that. But he was always able to rely on his physical health. And when he couldn't, he said, man, I really wish someone would have told me.
Yeah, and that's a really, oh, sorry, I was just going to say, that's a really good suggestion about having somebody set up, say, before the surgery happens, because there's still that stigma about mental health care, right? And so I think it's a good idea ecipe if more clinicians start adopting that when they're working, with patients coming out of surgery. Because I've been fortunate not to have to undergo surgery. And I don't mean to negate what pain means for people, but sometimes you just don't know when you're going into something. So like we had our kitchen and bathrooms remodeled at the same time. We're like, oh, it's just a remodel. We'll be fine. We'll use the grill to cook. And it was so stressful. Like we had no idea how stressful that was going to be. And I know that's not quite the same thing as pain, but just that idea of not knowing when you're going into something.
Yeah, and stress is stress. So if someone told you, hey, listen, this is going to take X amount of time, you will not be able to do any of XYZ that you're used to. Are you sure you want to do both of these things at the same time? You know what I mean? So having all those facts up front with your patient, and to be able to, like you said, deliver that with some compassion, with some empathy and understanding is really important. And as the therapist, the best way for you to do that is to be prepared with all the facts. So you can't go in and BS your way through this kind of stuff. Mm. So as the clinician, you better be prepared.
Mm-hmm. And what is a good recommendation for, first of all, I know it's difficult for us to see our own biases, but some of the other discussions we've talked about is, bringing them into the treatment room. And like you said, not giving our opinion, but there are things we think about what people do that if we're not aware we're thinking about them, it'll just fly out of our mouth. Like one of the examples when I had my massage practice, I saw a lot of CrossFit injuries. So I was biased against CrossFit, even though I had done it before. And I was pretty good about recognizing that, not letting that fly out of my mouth when someone came in and they were doing CrossFit. I was very careful not to tell them not to. But what are some good ways that a clinician, maybe they're observing it and they're not sure how they can be better about not letting that fly out of our mouths?
Yeah. Well, I mean, sometimes it does. We're only human, and I've had things fly out of my mouth that I wish I could take back, or an eye roll that I wish I didn't do that I didn't even know I was doing. So, I mean, these things happen. But I think if we can constantly keep the focus on the patient and keep asking those open-ended questions to really dig down deep into why the patient in front of us, the person in front of us is feeling the way they're feeling, I think that's a great way to take your bias out of it. Just keep digging deeper in with that patient. Keep asking those open-ended questions. Keep asking, a la Peter O'Sullivan, right? He just keeps digging and digging, and you'll never, he has opinions, but you don't see him in any examples that I've seen injecting them into the people that he's working with, because he keeps the focus on them, and he just keeps digging deeper and deeper into more questions. So it's like if you've ever taken improv classes, it's the yes and, right? So someone says to you, I woke up and I had this low back pain, and that was 5 months ago, and now I feel like I can no longer go for the walks I used to like to go for. And what you can say, instead of saying, well, what do you mean you can't go for a walk? That's supposed to be really good for you. Why would you not want to go for a walk? Instead of saying that, say, yes, and can you tell me how maybe not going for those walks are affecting other things that you're doing. And so now all of a sudden, it's not about the walk, you're digging a little bit deeper, and then you can go back and say, well, you know something, with low back pain, walking is actually really good for you. And so you kind of get a little bit deeper in order to build them back up. And it's hard, and it takes practice, and it takes a lot of people, and you're going to screw up a lot. And if you do, you can always apologize. You can always say, oh my goodness, I didn't mean to say that, or I'm sorry, let's keep this about you. This is not about my opinion. I mean, you're only human. People will appreciate that.
Yeah, so it just sounds like just stick with the practice of managing your patients like that, because I think a lot of clinicians, especially, you know, if they come to the summit or they hear all these talks and presentations and they're like, well, I don't think they realize how simple it can be to work from that position where you're putting the attention on the focus. It's a simple thing, but it's just so difficult for clinicians to do for some reason.
Well, it's difficult because it gets uncomfortable. Right? And no one wants to feel that discomfort. No one wants to dive deep into someone's feelings or really try and get them to open up and understand. And I think that's where maybe taking some classes, whether it's on cognitive behavioral therapy or ACT, or I think, you know, having, because we're not, I mean, I'm a physical therapist. I'm not a psychologist. I'm not a social worker. I'm not a psychiatrist. But I can certainly let people open up and tell me things. And from that, if you are hearing something that's setting off a red flag in your head, then you can make that referral out pretty quickly. And I've done that several times with people of all ages, from 11 years old up to 80. So I think but if you make it all about you and not about them, you'll never get to that point, and that can be dangerous for the patient.
Mm-hmm. And what is and of course we know kind of what the research tells us, but what is the value that you see with your patients if you can be direct with them, again, in a compassionate way, but the benefit that you've seen when you do give them the facts and you let them know what's truly going to happen? What have you noticed when you use that?
It's funny. The first word that came into my mind was relief. So that when patients are going through things and something happens that might be a little bit outside of what they thought, they're like, okay, it's all right. Karen said this might happen. And that's what they say. Patients come back and they'll say, well, I did X, Y, and Z, but then I thought to myself, and I felt this, then I thought, oh, well, Karen said this might happen, so I guess I'm okay. I can keep going. So it's this sense of relief, it's a sense of security within themselves and within the therapy that I think you get when you give all sides to things. And when you try and, you're not anticipating how they're going to feel 6 months from now, but you can at least give a roundabout way of what recovery may look like. You know, and people always say, oh, well, you said the recovery is not linear, and that it may go up and it may dip down and plateau and come back up and plateau and dip down and come up and plateau and go, you know, it's never a straight line. And everyone from, I have a 12-year-old that had an ACL reconstruction up to a patient who's 82. And they all get it because I'm trying to give them as much information as possible. To number one, know when they're okay. And to number two, know, oh, you know, this doesn't feel right. I had a patient who, she had already gone through basic rehab for a total hip replacement and was discharged. So then I started seeing her just for continued strengthening, and she had dislocated the hip at sleeping at night. It kind of got tangled up in the sheets and it dislocated, and she was like, okay, I'm pretty sure this is what Karen said this might feel like if this were to happen. And it relocated on its own, but she knew the next day, okay, call me. I went over, we got in touch with the doctor, and it was a done deal, you know, and it didn't inhibit her rehab or set her back in any way, shape, or form. So I think giving all sides of what recovery may look like, what the research shows, what it should look like or could look like, because we're dealing with real people here, not meaning real people in real settings, not in a controlled environment in an RCT. But I think what it gives patients is relief, it gives them some confidence, and also gives them confidence in you, and it helps to solidify that therapeutic relationship. And we all know that when you have a good therapeutic relationship with your patient, that outcomes tend to be better just because they trust you. They're going to do the things you ask them to do. They're going to tell you things when things are off. Because sometimes if you're not honest with the patient up front, how can we expect them to give that honesty back to us? So that's the way I look at it. It's always a two-way street.
And I'm curious, so what does it look like for, say, somebody's coming out of, they've come out of surgery, they've done their rehab, and, the insurance on that has run its course, but everyone's expecting them to be pain-free. Like they're expecting to be pain-free. How does that kind of a discussion go with a patient who's experiencing that from, of course, the clinician's perspective?
Yeah, and these are not easy conversations to have. And listen, some patients really are pain-free after a certain amount of time. What I always tell my patients is that let's not count on anything until a year after the surgery. You got to give it a year. And that's with any surgery. That's, I guess, partly anecdotal, but then there's some research to back that up, especially if we're talking about our ACL patients and things like that. I mean, if you're talking about athletes wanting to go back to return to sport, it's, these things take a year, right? If it's
I had a root canal, and he told me he's going to call me in a year.
What's that?
I had a root canal, and he said, well, I'll be calling you in a year from now. So that must be why. Mm-hmm.
Yeah. And for those people who expect to be pain-free, I mean, I've had patients who are like, what? Surgery was 3 weeks ago. How come I'm not pain-free yet? Or the surgery was 2 months ago. The doctor said I should be fine. And so I usually have the discussion, again, coming from facts and a physiological timeline of healing. Hey, listen, it takes 6 weeks for these tissues to heal. When you're like 18, I was like, so you're 72. So let's tack on a little bit of time here, And I'll also use the example of, well, if you were pain-free at 3 weeks post-surgery, and don't you think you might do something stupid and damage the surgery? Pain is there in an acute phase to protect you. So let's honor that for the first even 8 to 12 weeks of protection, and know that as things heal and as you move, the pain will slowly dissipate. If it doesn't, then we go into a whole different conversation of, okay, well, for whatever reason, your nervous system is still on high alert. What can we do to help with that? And maybe that's moving into graded motor imagery things. Maybe that's just moving into increased load. Maybe as a therapist, and maybe I haven't loaded the joint or the tissues enough in order for them to get stronger, in order for them to really have a good healing. So I think when that person kind of moves into that, I had surgery 2 years ago and I still have pain, that's obviously a completely different conversation than I had surgery 3 weeks ago or 3 months ago and I still have pain. And I think then we go right into the same conversation we would have for someone who didn't have surgery and still has pain. And it's definitely a harder conversation to have. It's keep the focus on the nervous system, not that there is still some damage done. I've had patients who've had knee replacements who still have pain 2 years later.
So then, like you said, the conversation shifts.
And that conversation shifts to, okay, well, at this point, we know that your nervous system is still on high alert. So what can we do? What does literature and research tell us we can do? What has worked in the past with other patients that might work for you? And so it's a different conversation and it's a different rehab process. Post-surgical, I mean, yeah, there's a lot of protocols you can follow. You kind of know the timeline healing, you know how to load things. If it's been 2 years, well, this is a completely different conversation. And now we have to say, yes, you did have surgery 2 years ago. That's healed. I can guarantee you it's healed. That is not the issue at this point. At this point, we're talking, you don't have a tissue problem. Now you have a pain problem. And now we have to deal with the pain. So it shifts. It shifts from, you have a disc issue, you have a knee OA, or you have a rotator cuff issue. It shifts to, well, now you have a pain problem, so now let's treat the pain as the main focus. And when I say that to patients, I think that gives them a little bit of relief, and they seem to get it.
Yeah, I like how you presented that.
What's that?
I like how you presented that, because because it's often, you know, patients will go in for recovery or whatever, and they do expect to feel better, and clinicians will feel stumped. You know, like they feel like, oh, well, how do I handle this now? Whereas what you're talking about is, okay, now your perspective needs to change, and the way you talk to your patient needs to change, rather than just think, okay, I'm stumped. I don't know. Just throw my hands in.
Yeah. So now we have a pain problem. So let's treat this what it is. It's a pain problem. And how can we now best move forward? And that may be consultation with a pain psychologist. That may be consultation with a registered dietitian. Let's look at what they're eating. That may be, hey, what are you doing in your spare time? What kind of relaxation techniques are you using? How much sleep are you getting? How much, you know, now we're talking about a real system-wide problem, because as we know, everything kind of fills up that bucket or that cup, if you're looking at things from a biopsychosocial viewpoint. So now we really have to cast a much wider net and say, hey, you know, maybe this has nothing to do with your surgery. And I had a patient who was having increased pain 2 years after a knee replacement. She had a thyroid issue. She had to have her thyroid radiated. You know, so you have all these fluctuating thyroid hormones kind of running through you. And she had inexplicably Hashimoto's and Graves' disease at the same time. Don't understand how it's possible, because that's a hypo and a hyper at the same time. One in, like, you know, a million people. But might that have contributed to her pain problem? Maybe. You know, so all of a sudden, instead of being a little microscopic post-surgical, okay, we've got a protocol, we've got to load things, we know how to kind of get people back, you really have to think about casting a wider net, because now you've got a pain problem, not just a tissue issue.
Yeah, so it sounds like it's just interesting, a lot of these conversations now about communicating with the patient and listening to the patient. And so it's interesting that these are like clinicians are being very interested in this, and they're interested in, you know, like you said, they could take ACT or motivational interviewing, but it sounds like maybe as clinicians, we need to think about being more comfortable with being uncomfortable when it comes to communicating with the patients.
Yeah, and I mean, there are times where, like, I don't like having these conversations. I want all my patients to feel better and everyone's happy, but you know, sometimes they're not, and you just have to be. You don't have to be the expert in how to deal with someone who's depressed. You don't have to be the expert in how to deal with someone who's got high stress. You don't have to be the expert. We know other experts who can do that, but you have to be comfortable having the conversation. You can't just say, oh, well, I'm sorry to hear that. Okay, let's go on to the next set. You know, it's okay, let's take a step back, sit down, let's talk about this, and let me see, how can I help you right now? And I think that's a big, big question that as therapists, we can ask our patients, how can I help you right now? What do you need help with right now? What can I do? Not what did you need help with last week, or what do you need help with a month from now? Right now, in this moment, what do you need help with? And is that something that I can help you with? And if it's not, I am happy to get you to the person who can. So as the clinician, I think the big takeaways are, you don't have to be the expert in everything. Surround yourself with really good referral sources and really good people. Take your ego out of it. Know how to reframe things for patients so that they'll understand what is potentially happening with their bodies and with their recovery, and what that may look like moving forward.
Yeah, I was just speaking earlier in another session with Amy Eicher, and she was, she's, you know her story, but she was talking about one of the things that she finds useful is if she gets a sense that the patient has shut down, so maybe she said something that the person didn't like, or maybe she reminds them of somebody they don't like, and when she senses that, she immediately will stop and say, what was it that I said that bothered you, or something like, something along those lines. And I thought that seems to really jive with what you're talking about, as far as when you talk with the patient and you're listening to them.
Yeah, I love that. Is there anything I said that bothered you? Or what is it that I said? I noticed a shift in the conversation. Is it something I said? Because, I mean, we're human beings. Like, we can sense when something goes from here to here, right? We can sense when a conversation starts to go off the rails. And I think it's important, again, that's an ego issue, right? So as a therapist, you have to say to yourself, okay, I just did something that this person did not care for. Let me find out what it is so that you don't do it again. Or maybe what they heard wasn't what your intention was.
That happens quite a bit.
All the time. All the time. You know, it's so you're telling me the pain's all in my head? I mean, we've all heard that, right?
You probably didn't say anything like that. And I like what you said a moment ago about what do you want right now? That is such a fantastic question, because I know when I had my massage practice, I would get clients all the time who would come in and they would have, like, say on their form, they've been having low back pain for a while, but yet they don't want you to address their low back pain. I had one client, she had low back pain, and I said, oh, so what would you like to do? And she wanted just her upper body worked on, because she likes cleaning her windows, and it was window cleaning time, and she wanted to be able to, move her shoulders. So that is such a good advice to say, what do you want right now? Because a lot of times it doesn't match what's on their intake form.
Right, and oftentimes it doesn't match what your plan is for them for the day. Because I know when I go to see patients, I mean, I have a rough outline of what I'd like to get accomplished during that session. But when I get there, I say, hey, tell me how you're feeling. Okay, all right, and what do you think you need to work on the most? And sometimes it's not really what I had in mind. And I'm like, okay, well, this is what I had in mind. So let's see if we can come together with a plan for today's session that meets somewhere in the middle. Because from a rehab standpoint, we need to do X, Y, and Z. And I understand you want to do X, Y, and Z. So let's see if we can meet in the middle somewhere. And again, that's a conversation to be had after you've seen that patient a couple of times, meaning that sort of melting of the sessions. In the beginning, sometimes, you have to do what is best for the patient, and you can't let the patient dictate the session. But
yeah, especially if their insurance is paying for their post-surgical care. You can't just be like,
right.
Oh.
Right. They can't come in like post-knee surgery and be like, oh, my shoulder is hurting me. I'd rather you work on that. No. Like that, then you say, well, listen, right now you just had surgery. We need to focus on your knee. And, if that shoulder becomes more problematic, let's do a proper evaluation, and then let's, have that as a separate issue. But it's hard to say, and I'm sure you've had people for massage. I've had patients come in and say, oh, well, I know I'm supposed to be here for my back, but I really hurt my ankle, so let's just work on that. And you're like, well, we need a proper evaluation. And then, so there is that fine line between what can I help you with today versus allowing the patient to dictate their session, because you're the professional. They're coming to you for help. And so you have to kind of walk that line.
And so as we're nearing the end of our time today for this discussion, which is just how we communicate with our patients just seems to be like something you could just talk about endlessly.
Forever, yeah.
What is something that for those clinicians who are watching this, what is something they can do? Either they're watching this on break and they're going to go back to the patient after this, or they're going back to work Monday. What's something they can start doing right now to be working from the patient's perspective?
So coming from the patient's perspective, and I'll use this as me kind of being a patient and a clinician, is when that patient comes in, listen to them every single time. Because oftentimes you may be the only person in their life that is there and listening to them. And so even if you're thinking in your head, what does this have to do with their pain? What does this have to do with physical therapy? Listen, you as the therapist, as the professional, it is your job to redirect that into how might this be affecting them physically? How might this be affecting their pain? But from the clinician standpoint, when that therapist comes in, you can use how can I best help you today? What is it you need help with today? Or tell me a little bit more about how your weekend was, or how the last couple of days were. How are you feeling? I know a lot of people don't like that question. A lot of therapists will say, oh, I never ask someone how they're feeling. It depends on the patient. I ask patients that question quite a bit. How are you feeling? And then you just sit back, let them speak, and then you can start your redirection, and you can start your, yes ands. So practice yes ands. That's a great thing to do for the clinician. Practice with your coworkers, practice with your family. The best way to do it is Rajan, we'll give a quick example of a yes and. So you go ahead and give me a statement, maybe something that you did the last couple of days.
Well, I was doing a lot of weeding and I stubbed my toe.
Yes, and the other day I was doing a lot. I was walking along the street and I saw someone, who stubbed their toe, fell to the ground, but luckily I was there and I was able to ask them how they were doing or if they needed any help. And then you would go on and say, yes, and after I stubbed my toe, I felt X, Y, and Z. And so you just kind of keep it going. So think of it like you're telling a story back and forth, and that story can go wherever it can. It could end up with an elephant in a tutu walking down the street. Like, don't worry about sounding silly, because that's what practicing, and that's an improv technique, that yes and. But as the clinician, what it does for you is it helps you to think on your feet. It helps you to continue a conversation. So I could have said, yes, and what did it feel like when you stubbed your toe? And then you can move on. And I could say, yes, and did you get all the weeding done? Did it stop you from all the weeding? You know what I mean? Mm-hmm. So there are tons of ways that you can keep connecting that. So as a clinician, as a take home, I would say practice that with your coworkers and with your family, and keep the story, try and keep the story going for 5 minutes if you can. It's really hard, because there are times where you have to be like, yes, and you have a big
I had a hard time starting it.
and you have even a hard time starting it. But I think for me, I found when it comes to communicating with my patients, those lessons from improv really helped me become a better communicator and a better listener and a better problem solver. So I would say for clinicians, practice your yes ands and see if that doesn't help with your communication. And because the other thing it does is it keeps you in the moment. Because when you're with your patients, you're communicating, you have to be in the moment. You can't be like, if you're talking and I'm sitting there and I'm nodding, yes, yes, but in my head I'm thinking, oh my gosh, I have to go home, I have all this weeding to do, I have to stop at the store, I have to, oh, I'm sorry, what was that? Right? But if you're doing an improv exercise and you don't listen to the person, you can't connect their sentence going forward. So it has a lot of practical application to what we do as therapists, and to sharpen our communication skills with our patients.
Yes, that is